All right, so we should be live now. Hi, everyone. Welcome to another Dental Shadowers virtual shadowing session. Today, we are joined by Dr. Smith, who is an orthodontist, and she has prepared a very exciting presentation for us today. So, Dr. Smith, whenever you're ready, you can go ahead and take it away.
All right, awesome. I'm Dr. Patrice Smith. Like Cooper said, I'm an orthodontist. I practice currently in Washington, D.C., and I'm really, really happy to be here. And I hope that whatever I impart on you today, whatever I share with you based on my own experiences will help you in some way, form, or fashion. All righty. So like I said before, I'm Dr. Patrice Smith. I'm an orthodontist, and I'm the owner of Infinity Orthodontics, which is located in downtown Washington, D.C. I was born in the beautiful island of Jamaica. I graduated high school at the age of 16, and I started college there. I later migrated to the United States, went to New York City, and did undergrad there. So I have 2 undergrad degrees, and I decided to stay in the United States. All right, so after undergrad in New York, I moved to Washington, D.C. That's where I did my dental school and my residency in orthodontics. After residency, I moved out of state to North Carolina, so I went south. So I enjoyed a little bit of warm weather for a while. And that's where I had my first associateship position, which associateship means your first job as an orthodontist. And this is where I met my amazing husband. He's a general dentist. And you can see all our photos on the right side of your screen. We moved to Pittsburgh, and that's where I had my second associateship position. We got married, we bought and sold our first home. Then after that, we moved to Washington, D.C., where I purchased my practice. So just a little bit more about me. Orthodontics and creating beautiful smiles is my passion. It's what I really, really, really love to do. But there are other things that I love and that I enjoy doing. And so this is where the whole work-life balance thing comes into play, where you don't necessarily want to be so linear, right? You want to work, but you also want to enjoy life. So you have to give room for the things that you love to do. So in addition to being an orthodontist, I'm also a blogger at theunorthodox.com. That's where I share not only my experiences, with career, but also I give advice. I aim to inspire, educate young professionals like myself and those coming behind me to live kind of a unorthodox, I like to say, lifestyle, kind of like different, not just so linear. And I talk about finances, career, lifestyle, and things of the sort. I'm also the owner of Unorthodox Candle Company. So I love, 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 love scented candles. And when I was in dental school, I had them all over my apartment. But they were expensive. You guys don't know this yet, but as a student, especially as a dental student, you're kind of broke. And so I always wanted to have candles, and they were a little bit pricey. So I had a bright idea one day to kind of make my own candles. And so I started making my own. Then my friends and family started asking for them, and then the demand grew and grew and grew. And then one day I decided to turn it into a business. And now I have a candle company that I supply candles to different people, and I even supply dental offices with candles, sorry. I'm also the co-founder of a dental nonprofit called Dental Helping Hands. We do mission trips, and we go to areas all over the world that don't have access to dental care. So we do that, well, before COVID, at least 4 times per year. And we've covered places like Jamaica, where I'm from, Sudan, Nigeria, Tanzania, and Ghana. So a little bit about my journey to becoming an orthodontist. So I told you I'm from Jamaica. I attended the Northern Caribbean University and earned my first degree in dental hygiene. So at the time in my country, there were no dental schools. I knew I wanted to become a dentist, but that was the only dental related program at all in the entire country. So I decided to take that course. But I was a dental hygienist for all of 4 months because I already knew I wanted to become a dentist. And that's what took me out of the country. So I migrated to New York City, and I wanted to really just get my prerequisites to attend dental school. But I had so many prerequisites to take that I said, I might as well get a degree out of it. And so I attended Medgar Evers College. It's of the City University of New York, that's in Brooklyn. And I obtained my bachelor's degree in biology. After that, I applied to dental school and got accepted to Howard University in 2010 for very tough but amazing years. And I graduated in 2014. In my second year of dental school, that's when I decided I wanted to pursue a specialty in orthodontics. So in my third year, that's when you have to, usually in your third year of dental school, once you've decided on a specialty, that's when you have to apply for residency. So I applied in my third year, and to get into residency, it's kind of a match program, which is very complicated to explain, but it's kind of like a lottery. And so you only get matched to one school. And so I was matched to my home school, which was Howard University, which was great because I didn't have to move, just continued. And that was a 2-year program. So I graduated from residency in 2016. So what is orthodontics, right? I'm pretty sure, a lot of people have an idea of what orthodontics is, but specifically it's a specialty of dentistry that deals with the diagnosis, prevention, and correction of malpositioned teeth and jaws. And it also has a focus on modifying facial growth. It's known as dentofacial orthopedics, which means modifying facial growth usually happens when a child is growing. And when they're growing, and orthodontists usually see kids at around age 7, when they're growing, it's a great time when you notice that their jaws might be misaligned. It's a great time to introduce, things like appliances that can correct that malpositioned jaw. And we can correct it and guide it into the proper place if they're young enough while they're growing. So it's actually more than just straightening teeth. It's kind of a pet peeve for a lot of us orthodontists when people say, oh, you guys just straighten teeth. No, it's a whole lot more involved than just straightening teeth. And we'll see that when I start to talk about cases closer to the end. So a little bit of advice for college, right? And I think a lot of individuals going into college or who are in college get to feel this kind of pressure to decide right away what they want to do. And I think my biggest advice, which is also the advice I give to my younger sister, is you don't have to have it all figured out. You don't. You go into college and you major in something that is of genuine interest to you. So if that's, music, or if that's communications or marketing, you do that because that's what you love to do. But if at some point during your college education, you decide that you want to pursue dentistry, you can always add those prerequisites for dental school to your curriculum or your course load, regardless of what your major is. I had classmates in dental school who were English majors, who were music majors, who were engineering majors, and they took the prerequisites for dental school because they decided later on that that's what they wanted to do. And they turned out to be amazing dental candidates. And they actually were unique, which might work in your favor when you're applying to dental school because it's different. You bring a whole different, unique set of skill sets and knowledge to, I guess, the dental arena, So it's actually a plus. So a lot of people think that they need to major in the sciences, and that's not necessarily the case at all. You're going to take the science credits anyway because you need them to get into dental school. But if you major in something else, it might just be advantageous. Okay, so to become a well-rounded applicant, of course, you have to have good grades. That goes without saying. It helps if you're involved in different organizations on campus and be in different leadership positions. It helps to shadow different dentists. It helps to shadow different specialists in dentistry because it shows genuine interest. It shows the admissions committee genuine interest in the field. And it shows them that you actually know a little something about what you're getting yourself into. Research is a big plus because you do have to, it's a big plus, it's not a must, but it helps because at some point in your dental school career, you may have to do research. As a matter of fact, I did research all through undergrad, all through dental school, even in orthodontics residency. So it's kind of one of those things where you can't really dodge and escape it. So, and it looks really great on your application. So I would suggest getting into some research. Science related would be preferred. And of course, the dental admissions test. You need that to apply. Try to get a really good score because those are what's weighted the most, your DAT scores, your grades, and then everything else that makes you a well-rounded applicant afterwards. So that would be my advice for anyone in college. All right, so a typical day in orthodontics. Well, a typical day in my practice, I work 4 days per week. I always tell that I do have what I call mentor Mondays in my practice, where I allow dental students to come in and they shadow. I do like to tell them that honestly, a 3-day work week is my sweet spot. I am open for 4 days out of my practice. The 4th day right now is kind of an admin day. So it's not necessarily patient care days. They're an admin day. 3 days is my sweet spot when I'm at work. For 3 days, I'm all in, 110% focused. The other days, I get to focus on my different passions that I mentioned. So I leave room in my life for life to happen. Because honestly, life is not all about work. You know, career is important, work is important, but it's not everything. I know some dentists that work 6 and 7 days per week. More power to you if that's what you want to do, but that's not what I want. And the great thing about orthodontics, why I chose orthodontics, is that you really can have the lifestyle that you want. You can work as much or as little as you want. And for me, that's great. Also, for me, why I chose orthodontics is it's clean. I don't deal with a lot of blood. I rarely deal with a lot of, with the exception of some kids who you can coach into great oral hygiene habits, I don't deal with a lot of kind of gunk, for lack of a better term. My days are not very stressful. And nobody hates me. Everybody loves the orthodontist. A lot of people have this phobia for the dentist, and then they end up saying, "Oh, I hate going to the dentist." I don't have that problem as an orthodontist. Everybody loves the orthodontist. Nothing is painful. Appointments are quick. And for the most part, our environment is very relaxed and very fun. So, like I mentioned before, 4 days per week in my practice. We're open Monday through Thursday. I have a boutique practice, which means I see a low volume of patients, typically 45 per day, and I focus on really building relationships with my patients. I focus on customer service, and I deliver that quality care that anybody would want. I don't have waiting times in my office. If you have a 2:00 appointment, you're getting seen at 2:00, not 2:30, not 2:45. And that's what my practice is, a boutique feel. So we pretty much start our day at 8:45. We have a 10-minute huddle and we kind of go over our schedule and prep for the day. We start seeing patients at 9 and we work until 1 p.m. where we get a 1-hour lunch break. And our last patients are seen at 4:30. And typically at 5 p.m. we're wrapping up. And we do that for 3 to 4 days per week. So that's a typical day pretty much in the life of any orthodontist. Now, 45 patients per day is also my personal sweet spot in my practice. I mentioned before that I had an associateship position right out of residency. And that first job that I had was at a very high volume practice. High volume, meaning myself and another doctor, we were seeing about 200 patients per day. 200. So split down the middle, I'm seeing 100, the other doctor is seeing 100. And it was great, amazing experience. We learned so much because we saw so many different cases, and it helped you to kind of think on the fly and work on your speed. But for me, that was a little too much. I ended my days very tired, very burnt out. And personally, now that may be great for somebody else, but personally, I didn't see longevity in a schedule like that. My next opportunity after that, my next job after that, I was seeing about 85 patients per day, which was good, not bad, not 100, so better. But still, it wasn't my sweet spot. Right now, my sweet spot is about 45 per day. That way I have time to make sure that everything is done correctly. Patients get that quality care, and we end up building that rapport and that relationship, which is so important, especially in orthodontics when you're seeing patients for a period of up to 24 months. All right. So what kinds of complaints do patients present with? So in orthodontics, the most common issues are, well, patients usually come in and say, oh, I don't smile in photos. I don't like my smile. Well, why don't you like your smile? It's usually issues of crowding, which means your jaws are small, which sometimes have your teeth kind of bunch or crowd together or overlap. Sometimes there's spacing, which means you have spaces between your teeth. Sometimes there are missing teeth. And by missing teeth, it could be due to extractions. You got it taken out because of some reason or another, maybe due to cavities. Or missing teeth could be they're congenitally missing, which means you weren't born with them. Impacted teeth, where because typically due to a small jaw, the teeth get kind of hung up. And we usually see those with canines, especially maxillary canines. Also wisdom teeth. Wisdom teeth get impacted a lot. But a lot of the cases that I treat with impacted teeth are usually canines when they get impacted or stuck. And usually the orthodontist has to go in, has to intervene, and kind of help to guide them into place. Excessive overjet. Excessive overjet meaning, for lack of a better term, what people would call buck teeth, or when your top teeth kind of stick out. Excessive overbite is kind of when you bite down and your top teeth overlap your bottom teeth a little too much. We have dental malocclusions. We have a class 1, class 2, class 3 dental malocclusions. I won't go into the definitions of those specifically, but class 2 is usually when your top teeth or your top jaw is forward of the bottom jaw. And in class 3 is quite opposite, where the bottom teeth or the bottom jaw is forward of the top jaw. Either way, the teeth don't necessarily fit together properly. And also we have jaw or skeletal discrepancy issues warranting surgical intervention. There are 2 phases in orthodontics. There's phase 1 and there's phase 2. Usually phase 1 is called interceptive orthodontics. And I mentioned this before, but we can start seeing patients at around age 7. So age 7, when adult teeth start coming in, sometimes parents will notice, that doesn't look right. Something is a little bit off. Let me take them to the orthodontist and see what's going on. It's also the phase where we can modify growth. I mentioned dentofacial orthopedics. So you can guide the jaws into its correct position or with the introduction of appliances. All right, and same thing for kind of malposed teeth, usually with crossbites. You can introduce an appliance that will alleviate the crossbite, that will prevent further issues down the road. If the child, say, has habits like thumb sucking habit or a tongue thrust habit, you can introduce an appliance that, 1, helps to stop the habit, and 2, helps to kind of, because the habit is broken, kind of guides the teeth back into place without having to do full braces or orthodontics. Usually when patients go through phase 1 treatment, after they develop all their adult teeth, they can move into phase 2, which is comprehensive treatment, which is braces on all the teeth for proper alignment. All right. What kinds of procedures do orthodontists perform? Okay, so I'm just going to walk through from beginning to end of, say, a person that walks into my office and is looking for orthodontic treatment. So it starts off with a consultation. And consultations are usually in person. And now with COVID, I do some virtual consultations where individuals can take photos of their teeth in different positions, and we guide them as to how to take those photos. They submit them to our office, and I can virtually look at everything, and then do a call like what we're doing now and kind of discuss what I see. Of course, at some point, they do have to come into the office because I do have to take x-rays, because sometimes there are things that are going on within the jaws that I can't see without an x-ray. So it starts with a consultation where we take or exam the mouth, and then we take our records. Our records include photographs of the insides of your mouth. So they're called intraoral photographs, pretty much your bite, extraoral photographs, which are usually the facial photos, usually in profile or in straight on, usually smiling, then smiling, just to get a picture of your facial aesthetics and to see if there are any asymmetries or things like that, to assess your smile and the balance of your face. Because orthodontists, we don't just treat teeth, we treat the whole face, okay? We also take our panoramic radiographs or Panorex radiographs, which is a radiograph of pretty much half your face, including all your dentition, and a cephalometric radiograph, which is usually a profile x-ray, which shows your skeleton from the side and how your teeth fit inside your bones and all that stuff, for keeping it very simple. And in my practice, we take intraoral scans, which when we go in, I use an iTero, which is an intraoral scanner. If you're not familiar, just do a quick Google search. We scan all the teeth. That way we can look at the teeth without the patient necessarily being there. So I can look at the teeth after the patient's gone, and I can assess everything without them actually being in my chair. After that, if the patient goes forward with orthodontic treatment, we bond the braces on. And there are different types of braces. Typically we see the traditional metal ones, but now there are ceramic, which is the clear ones, which is more aesthetic. We have gold. Some people love gold. There's gold now. There are self-ligating brackets, which means it's kind of keeps, very simplistically put, keeps the wires within the brackets very passively, and they have these little doors instead of using the little colorful rubber rings to go around the brackets like our traditional. Self-ligating, which means the bracket itself keeps the wires within its slots by using these doors. There's also lingual braces. Lingual mean on the tongue side, so lingual braces goes behind the teeth. It's even more aesthetic. And then of course there's Invisalign, which are clear aligners. I say Invisalign because that's the name that most people recognize clear aligners by, but clear aligners is really the proper term. Invisalign is just a brand of clear aligners. After orthodontic treatment is finished, then we debond the braces, which means we remove them, we polish the teeth, we take the same set of records again, and sometimes we also place different appliances for different types of malocclusions, like I discussed before. So diagnostic tests and instruments that we use. I mentioned all of this before that I use to help me with my diagnosis. Sometimes we also use a cone beam CT, which means pretty much 3D imaging. So you can see the whole skeletal structure in a 3D plane of space. New technology in orthodontics. So this is pretty fun. For the most part, a lot of people these days are going with clear aligners because they don't want to necessarily go with braces nowadays, even though it's still an amazing option. But they like Invisalign because it's a clear way to straighten your teeth. We have the intraoral scanning, which I mentioned before. I personally use an iTero. There are a bunch of different scanners out there, but I personally use the iTero scanner. We have 3D printing. So what 3D printing is, basically, I scan the teeth with my iTero scanner, and I can send it to a printer that prints out a 3D model of the teeth. In dental school, you'll learn that you can take an impression of the teeth. We've replaced the impression with a scan, and then you can pour up that impression in plaster. And we've replaced that plaster with just printing it, 3D printing it. And from that 3D printed model, we can actually make our different appliances. We can even make clear aligners from that 3D printed model, which is amazing. Patients love it because they don't have to have that goop or gooey stuff in their mouth. And we love it too because of the same reason. And also, it's so quick and efficient and clean. Orthodontists love clean. Now they have custom braces. So typically, we have braces that kind of like the treatment planning is custom, but the braces are kind of a one size fit all. But now on the market, we have custom braces where braces are 3D printed specifically for you, which is very exciting. And I put in bracket light for us because that's the company that introduced those custom braces. In addition to custom braces, there are custom wires, which is bent by artificial intelligence, like pretty much robots, and is custom for you, the specific patient. So very exciting. And of course, lingual braces, like you can see all of those in the pictures on the side. All right, so now for the fun stuff, some cases. So I mentioned before that one of the most common reason people get braces is usually because of crowding. It's usually because of crowding. If you look in this picture, you can see that the teeth aren't necessarily aligned. The teeth aren't in the places where they're supposed to be. And it's typically because of a smaller jaw that can't accommodate all the teeth. So in this particular case, we have a severe amount of crowding, and that's in the upper and lower. And for this case, I deemed it necessary for proper alignment that we have to remove teeth. And typically in this kind of case where we have class 1 malocclusion, and by class 1, I mean you look at the first molar teeth, and it's pretty much where, I don't know how much you guys know about this, but you have a lot of time to learn this stuff. But it's pretty much how the molars sit together. That tells you the type of malocclusion that the patient has. This patient has a class 1 malocclusion. And typically in class 1 malocclusions, when we have a crowded situation, we want to extract first bicuspids. So the first bicuspids, or the first premolars, are those premolars that are sitting behind the canines. So this is what we did in this situation. So we extracted the 4 first bicuspids, 2 in the upper, 2 in the lower. And on the next slide, you'll see how the alignment came out. So after about 18 months in treatment, using traditional braces, and after 4 teeth were removed, this is the alignment that we get. Patients very, very happy. They now don't have crooked teeth, and they're much more confident than how they came in 18 months. Another common reason people get braces is spacing. You know, they come in and they say, well, I have these spaces and I don't really like them. Can we just go ahead and close them? Very common issue, and it's pretty simple to do. Sometimes we have spacing for different reasons. Spacing because somebody lost a tooth due to cavities or whatever reason. Sometimes because they weren't born with a tooth. In some cases, the orthodontist will align the teeth around that space and leave that space to get an implant. That's an option. It just depends on the situation. Sometimes you get spacing because of a tooth size discrepancy, which means some teeth are a lot smaller than what they're supposed to be. And in that case, the orthodontists align the teeth and then leave the teeth that are much smaller in size to receive a buildup or a veneer or a crown after orthodontic treatment. So for example, if we look at this particular case, if say the lateral incisors, which are the teeth that are beside the two front teeth in the top, say they were peg-shaped or very, very tiny, I will never be able to close all that space and get an aesthetic result because those teeth are much too small. So what the orthodontist would do is we'll close the space, we'll close it to an extent and leave the ideal amount of space around that tooth so that after orthodontics, this patient can go to a cosmetic dentist and have that tooth built up, meaning they put composite tooth colored material around that tooth to build it up, or they get a crown or they get veneer. But in this particular case, we were able to just close the spaces and the patient was very, very happy at the end. And this took about 8 or 9 months. The patient was very, very happy. Spaces are closed. I'm now more confident to smile in my photos. Another topic or another issue that patients sometimes present with is called a crossbite. And a crossbite is a type of malocclusion where the upper teeth fit inside the lower teeth. And this particular patient has an anterior crossbite. It's in the front. So the top two front teeth are inside the bottom teeth. And of course, they don't like it. It's not very attractive, and it's not the proper bite. So sometimes the orthodontist will go in, align the teeth, pull those top teeth out, and the patient ends up being very, very happy. And now they have the most ideal bite, like you can see in the next slide. So no more crossbite, ideal bite, patient's happy. And this also took about 9 months. This patient actually did ceramic brackets, so the clear ones. I guess he figured, I already have a crossbite, I don't want to draw more attention to it. So he went with those clear brackets or clear braces. So in this particular situation, we have a deep bite. I mentioned earlier, excessive overbite, also called a deep bite. So this patient actually has mixed dentition. And what mixed dentition means is we have a mixture of primary teeth, baby teeth, and adult teeth. So the patient hasn't gotten all her adult teeth yet, which means she hasn't lost all her baby teeth yet. We have a lot of crowding, and we also have a deep bite. So we have a few things going on here. So what we were able to do in this situation, because she was very close to losing those baby teeth, went ahead and had those baby teeth removed. And because she was so crowded, because she has such a tiny jaw, we also did that 4 bicuspid extraction like we did in a previous case. We also had to lift her bite up to give you a more ideal bite so that she doesn't have that deep bite. And if you look in the photos and look at her picture when she's biting down, you can't see any of her bottom teeth. It's a deep bite. Those top teeth are covering the bottom teeth to the point where you can't necessarily see those bottom teeth. So if you go to our next slide, then you'll see that we had bicuspids extracted. So now she only has 1 bicuspid on each side. And we alleviated that deep bite. So now when she bites down, you can see top and bottom teeth. It's more aesthetic. This treatment time was 24 months, which is typical for a more complicated case in orthodontics. Typically, patients are with us for about 2 years. This is a really, really fun case, and we sometimes have to work in conjunction with the surgeon, an oral surgeon. So this particular case, this patient presented saying, my teeth just don't fit together properly. I can't get them to fit right, and it's really bothering my jaws, and it doesn't really look good. So after my assessment, I realized, okay, so I didn't include the x-ray in these photos, but on the x-ray, he had a jaw discrepancy. One of his jaws was a little bit retruded. It was the top jaw. It was set back. So it made the appearance like the bottom jaw was forward, but it was really the top jaw. If you notice in the photos, the patient is biting kind of edge to edge. Is biting on the edges of his teeth, which ideally your top teeth are supposed to cover your bottom teeth for ideal overbite and overjet. So he has a narrow and retruded maxilla. Maxilla is the upper jaw. If you look at the photo, kind of right below that side view of the teeth, yes, it's very, his maxillary arch is very narrow. You want to see a wide U shape. This one's it's kind of like a narrow U. So he had a very narrow maxilla, and it was also retruded, meaning it was set back. He had dental malocclusion. He was class 1 on one side, class 2 on the other side. And when you look at his smile, there's a line that goes right down the middle of your face. It's called, your facial midline, and your teeth should fall on that midline. And when you look at his teeth, the top teeth were saying one thing, the bottom teeth were saying another thing, and then his face was another way. So nothing really fit together properly. And so I deemed that this patient needed orthodontics in addition to surgical intervention. So if you go to the next slide, we started orthodontics and we had all the teeth aligned. And this took about 12 months to get the teeth aligned. And if you look at that upper arch, like I mentioned before, it's now a nice wide U. It's no longer narrow. And we did the same thing to the lower arch. It's called decompensating the arches, which means you put the teeth kind of like in solid bone and you make them stable. Now we still have the malocclusion, but that is where surgical intervention comes in. So like I mentioned before, it took about 12 months for us to get the teeth aligned and over basal bone, which is solid bone, where they're supposed to be. And the surgery that was done was a maxillary advancement, because I told you the maxilla was retruded. So they would advance the maxilla, which means to put the maxilla forward, and a 3-piece Le Fort osteotomy. This is where the maxilla is expanded, because I told you he was narrow. So they would expand the maxilla, which means they cut between the lateral incisor and the canine and kind of expand that maxilla. And they also cut below the nose and pull that maxilla forward. If you are not squeamish, you can go on YouTube and you can type in Le Fort 1 osteotomy or Le Fort 1 orthodontic surgery or a 3-piece maxillary surgery, and you get an idea of what took place here. So after 12 months, I referred him to the oral surgeon. The oral surgeon did the surgery. The patient had about 6 weeks of downtime where he pretty much couldn't do much of anything. He had to have a kind of a smoothie diet. He couldn't eat any solid foods. He had to pretty much drink all his food. But that was 6 weeks. He healed up very nicely. She goes to the next slide. And so 6 weeks of healing. He followed up again with orthodontics. I did some more alignment to get those teeth to come together really nicely. About 3 more months of orthodontics. So the total treatment time was about 17 months. Orthodontics, surgery, midlines are on, the bite is on, the teeth are in proper occlusion, and he's very happy. And now, when you do surgery, your facial profile is also going to change. So if you wanted to compare, I think the next slide I have a comparison of all the stages. You notice his facial profile changed. It actually is more balanced now. In the very first one, you can see a little bit of asymmetry in his jawline. His smile is not as wide. He's more, in the very last photo, the final photo after surgery and ortho, he's a little bit more full in his cheeks, which means his maxilla was brought forward. Overall, more balanced facial profile, and he's happy. So this is when you have a situation of orthodontics mixed with surgery, which we do from time to time. Alrighty, so advice for our future dentists. And I tell this to anyone who's interested in dentistry. The glamorous portion of dentistry comes with a price tag. It's not easy. It's extremely hard. Going through training is difficult. Dental school is very challenging. sometimes back-breaking work, and countless sleepless nights. I know in dental school, it was probably the best and the worst 4 years of my life. So the profession is to be enjoyed, but also respected. Make sure if you do go into this career that you really truly go into it for the right reasons and that you go into it because you love it. There are students that I know that go into dentistry because of probably the lifestyle that they see that dentists have. Dentistry offers you an amazing lifestyle. And so some people get caught up in just the lifestyle portion and they go into it because of the money. Well, I can tell you that those patients, not those patients, but those people, sorry, they end up being a little bit unhappy with the profession because it's so much work. You really have to love it. You really do. So that's my one bit of advice I would give to you if you're going into dentistry, do it because you love it. And I have to say also, dental school is expensive. It's extremely expensive. The average dentist that graduates now graduates with at least minimum $300,000 in debt. If you add orthodontic residency to it, it's easily another 150. Most orthodontic programs, most orthodontic residencies, the residents don't get paid. You pay tuition. So if you go into dentistry, if you go into orthodontics, make sure that you love it because it's just too much, too high of a price to pay for something that you don't like. I also know individuals that go into dentistry or went into dentistry and ended up saying, you know what, I don't want to do this anymore. They're stuck with the debt. And whatever career they end up doing, you don't get the return on investment to pay that debt down. So do it for the love, not for the money. You make sure you really enjoy it. That would be my advice. All right. Yeah, you can find me on social media. My handle is down there. Through my social media, through that handle, you also find my other platforms, my blog, the Candle Company, and my practice, and also my nonprofit. So feel free to follow my page. You also feel free to, you can email me, DM me, ask me questions. I'm always happy to help.
Awesome. Thank you so much, Dr. Smith, for that wonderful presentation. And yeah, everyone, make sure you go check out Dr. Smith and all of her amazing endeavors. And so now, Dr. Smith, we're going to take a few questions from the chat.
Okay. All right. Sure.
So our first question is, why did you pick orthodontics versus any other specialty?
So I actually started my first year between orthodontics and oral surgery. Interestingly enough, I'd like to say it like this. Oral surgery and orthodontics could not be more opposite. Oral surgery it's a lot more training. Oral surgeons after dental school go through 4 to 6 additional years of training. And then also, it's a lot more involved. It's surgery. If you do a 6-year program, you also have to do medical school. So it's 4 years of the oral surgery aspect and 2 years of medical school. That's one of the reasons I didn't want to do it. And also, it's a personality thing. I have the personality where I like to take my time. I'm more of a kind of a cognitive person. I like to see the cases and I like to process the steps it takes to get from point A to point B. As an oral surgeon, and frankly, any other specialty, you kind of have to think on the fly. You have to go. You have to think, okay, boom. And I'm not that type of person. And it comes from pretty much knowing yourself. Have an understanding of who you are as a person. I like to take my time to make decisions. And in orthodontics, it gives you that opportunity. Also, orthodontics is clean. I don't have to deal with a lot of blood. And people refer to the orthodontic profession as the thinking man's profession. It's very cerebral. You have to begin a case with the end in mind. You have to be able to, it's kind of like perceptual ability and the dental admissions test. You kind of have to see the end before you even begin the case. And for me, I encompass all those things. I am very cerebral, and I like to take my time. And the bonus in orthodontics is nothing you do in orthodontics is irreversible. For a general dentist, if you remove a tooth is gone forever. Can't do anything about it, can't put it back. In orthodontics, if you move the tooth in this direction and just like, well, actually the tooth's supposed to go here, I can always move it back. Everything's reversible. So there are a lot of things in orthodontics I love. And in addition to that, the lifestyle. You can work as much or as little as you want, and you still manage to make a really good living. So those would be my reasons why I chose orthodontics.
How competitive is orthodontics versus any other specialty?
Oh my goodness. I think orthodontics and oral surgery, those are probably the two main specialties that are the most competitive to get into. It's extremely competitive. For both those specialties, you have to be in at least the top 10 to 15% of your class. Very competitive. On a scale of 1 to 10, it's between a 9 and a 10.
Wow. How did you like Howard Dental School?
I loved Howard University. You know, it's funny because growing up in Jamaica, most of the dentists that I knew, most of the dentists were trained at Howard University. And so I always had it in my mind, when I go to dental school, I want to go to Howard University, because that's what I knew. That's where everybody went. So that's where I wanted to go. But, you know, going to Howard University, it really, really was a family-oriented environment. Everybody wanted you to succeed. Everybody kind of cheered everybody on. You know, everybody was kind of involved in your success. You know what I mean? All my colleagues, you know, they went to a bunch of different dental schools, and we share our stories. There's some dental schools where it's so competitive to the point where you feel isolated. That was never the case at Howard. We all worked together, and that I didn't realize it at the time when I was in dental school. But when you get out and you interact with all these different people from all these different schools, you realize that, well, I realized that dental school at Howard was unique in that way, where everybody was kind of like a family. You know, we never wanted to see someone else get left behind. You know, if somebody was struggling, we all corralled and we all made sure that we all were doing things together. Listen, we're all going to matriculate. You know, nobody was for themselves. There wasn't any like cutthroat mentality. Everybody made sure everybody won, pretty much. And so that was the main thing. Now, I will say that Howard University may not have all the bells and whistles of other programs. And by bells and whistles, what I mean is the latest technology. I don't know if they do now, but when I was coming through dental school, they didn't have stuff like a cone beam CT, like 3D imaging. I don't know if they do now, but that was one of the things where other schools had it, and we were just like, oh, I wish we had that. You know, so they're not going to have necessarily the bells and whistles, but what they lack in kind of bells and whistles, they make up for in camaraderie. It really was a nurturing environment. And, you know, you succeed because of that. Everybody wanted you to win, and everybody made sure that you progressed. Everybody was part of your success. Yeah.
Why do you think malocclusion is so common in humans nowadays? Do you think it's evolutionary?
That's a good question. You know, I see a lot of patients where, and I believe it's kind of like an evolutionary thing, where our jaws are actually becoming smaller and smaller, which is why most people have to get their third molars, their wisdom teeth, removed. A long time ago, our jaws were big enough to be able to accommodate all the teeth, all 32. But nowadays, most of us, I hardly see anybody who has the full complement of teeth in their mouth. And evolutionary wise, we're becoming smaller people, smaller jaws. And so we're finding that our jaws can't accommodate all our teeth anymore. I think over time, as we continue to evolve, we are not going to be developing third molars anymore, because our jaws are not going to be able to accommodate them. So they just will become obsolete, which is evident because I see a lot of patients, most of the third molars become impacted. And if they're not impacted, they're just congenitally missing. So we're literally in the middle of evolution. Yeah.
What is the breaking point to recommend someone for correctional jaw surgery, whether it is under or over bite?
The breaking point is usually over a certain, we do different measurements of the facial structures, and it's a lot that goes into the diagnosis. But there's a number that after it passes that number, then it's like, okay, it's past the point where I can orthodontically do this and get a good result. You know, say for example, if my overjet, which is how far my top teeth sit from my bottom teeth, if my overjet is more than say 8 millimeters, then that clues me and say, hey, okay, I can't correct 8 millimeters with just orthodontics. Sometimes you can extract teeth and get that, but it depends on what the skeletal structure dictates. If the skeletal structure won't allow you to extract teeth and retract those teeth to get a proper alignment, then that's indicative of surgery. So it's a lot that goes involved in the decision making to go into surgery. It's a lot of diagnostics. It's a lot of your x-rays and a lot of measurements. It's a little more complicated, but I'm trying to keep it simple. But it's involved, and it's pretty much, it's past a certain number that clues you in to say, hey, okay, we can get this accomplished without surgery.
Are most of your patients children? About what percentage or ratio?
Okay, so in my particular practice, I am downtown DC, which means I'm in the middle of the city. My percentage of patients goes a little like so. So I have about 80% adult patients and about 20% preteen and teen patients. That's in my practice now, and it's because of my location. So the first associateship position that I had, which was in North Carolina, because of that practice's location, I saw 95% kids, maybe 5% adults. I barely saw adults. In my second practice, again, because of the demographics and location of the practice, I saw about 70% kids and teens, 25% adults. But you have to, as an orthodontist, as a dentist, you have to choose your practice location based on what your preference is. For me, if I wanted to see mostly kids, I'd have to position myself probably in the suburbs, probably in a community with growing families. I decided to position myself in the middle of the city. So that dictates the type of patients that I will attract. And right now, they're mostly adults, which means it's mostly options that are more aesthetic, like Invisalign and lingual braces.
What would you recommend doing now during COVID in addition to virtual shadowing?
You know, if the dentist will allow you to actually come into the office, then I would do that, because virtual shadowing is amazing, it's great, it's convenient, but nothing kind of beats that in-person interaction if the dentist will allow you to. I know I do in my practice. What I call them mentor Mondays. I allow them to come in on Mondays, which are usually my busiest days in the practice. And so that they can get that hands-on kind of shadowing experience. And they pretty much just have to check all the boxes, you know, your COVID form that says, you know, have you traveled outside of the US? Have you traveled outside of the city? Do you have any of the symptoms? And most recently, have you gotten your vaccine? And they're required to wear an N95 mask, a level 3 mask, and all the PPE. They pretty much have to adhere to whatever protocols my practice adheres to, and then they're allowed to come. If you don't have your vaccine, or if you don't, if you've had any of the things that are listed on the COVID sheet, of course, you're not allowed to come. But I do have that situation where I do allow students to come to my practice. So just reach out to the dentist and see if they would allow you to come, because nothing beats that in-person shadowing experience. Virtual is great, it's amazing, but it's different in person.
In some cases, could braces actually worsen teeth prior to surgical intervention, or is that not possible?
Worsen teeth. Say that question again, because it had a surgical component.
In some cases, could braces actually worsen teeth prior to surgical intervention, or is that not possible?
I would say no, not necessarily. The only time braces worsens teeth in a general, very, very general sense is usually when I see a hygiene issue. So patients will sometimes ask me, oh, I don't know if I want to do braces. Braces ruins your teeth because when you take them off, you have these little white squares. And that's where I say, no. Braces doesn't ruin your teeth. Your teeth gets ruined when you have a hygiene issue. So if you have braces, you're going to have to be a little bit more diligent with getting your teeth clean, because with braces, it's kind of a trap for all the food debris and plaque. So you have to be really diligent in getting rid of that plaque. If you don't get rid of that plaque is sitting on the teeth. The plaque contains bacteria, which sits on the teeth and causes demineralization of the enamel. That's why when you take the braces off, you get these little white squares, because the enamel has been demineralized. A lot of people, especially younger kids, aren't usually very diligent with oral hygiene, and that's because they're kids. But that's when you'll see a little bit of damage to the teeth, after braces comes off. But in terms of prior to surgery, not necessarily. No, because pre-surgical orthodontics is pretty much putting the teeth where they're supposed to go, and then the surgeon then aligns the jaws in the proper alignment of the teeth. So no, it makes it better, not worse.
What made you pursue dental hygiene at first if you already knew you wanted to become a dentist?
So at the time when I graduated high school, I was living in Jamaica. That's where I was born. That's where I was raised. And the country didn't have a dental school at the time. Dental hygiene was the only dental related program on the entire island. So I knew I wanted to go into dentistry. That was kind of my way to get into anything dental related. And it's pretty much because the country didn't have it. Now, of course, I migrated to the US, did undergrad, and then when I started dental school, that's when my country got 2 whole dental schools. What do you know? But that's the reason. Would I have done dental hygiene had I had the option to just go to undergrad and do dental school? Probably not. However, because I did dental hygiene, I was more prepared for dental school. So it actually helped.
Which college time was harder, undergraduate or graduate?
Oh, definitely dental school.
Yeah.
Definitely. 110%.
Or during the residency, maybe?
Dental school. Dental school was harder. Residency had a different kind of challenge, because orthodontics was so different from anything dental. Orthodontics was, how do I say this? It was so cerebral, and it involved, you had to think differently. It's so interesting because it's not just about straightening teeth. It's a lot of physics involved. And so if you do decide to go into orthodontics, you have to pull on the physics skills from college. So it's a lot of physics. I mean, it's a lot of biochemistry. It was different. After you pass the first 2 years of dental school, the rest of dental school, the third and fourth year, you're pretty much doing clinical. So you're pretty much just doing mechanical stuff. You're cutting preps, you're doing fillings, you're doing root canals, you're doing extractions. But then you go into orthodontics, and then you're mostly thinking and diagnosing, and the treatment, actually doing the work. And as an orthodontist, to be honest, you don't necessarily do the actual changing of the wires and putting on the O ties. You have your dental assistants or your orthodontic assistants or your clinical experts for that. The orthodontist job becomes the brain, the diagnosis, the treatment planning. So very different, but I would say a different kind of challenge, and dental school was definitely more challenging. Dental school, it's like, what should I say? In my first year of dental school, my first week of dental school, I feel like my first week, I learned a whole semester's worth of information in 1 week. And that's the pace of dental school. And you have to keep up. And it's exhausting and it's tiring. I remember going through dental school, and I'm not trying to scare anybody. I'm just trying to tell you that it takes a lot of work. I remember in dental school being so exhausted and so tired that I called my mom and told her, look, I'm coming home, I'm quitting. This is too much. But not that I wanted to quit, I'm never going to quit, but you get to that point of exhaustion because I've had a lot of sleepless nights, pulling a lot of all-nighters. It's a lot of work. And especially those first 2 years, it's a lot of didactics, it's a lot of studying. And so it's very different from undergrad. Undergrad, you kind of do your courses, take your time, la-di-da-di-da. And then you get to dental school and you're thinking, I know it's going to be harder, but la-di-da-di-da. And then you're like, hold up, wait, I can't la-di-da-di nothing. I have to focus. So very different, very fast-paced, very rigorous. So you can't even mentally prepare. It's kind of, you get thrown into the fire and it's sink or swim kind of thing. But totally doable. You have a million dentists out here. So yeah.
Thank you, Dr. Smith. That's all the time we have for questions. I will send the attendance quiz right now in the chat.
Okay. All right, awesome. Wonderful. Well, thank you so much again, Dr. Smith, for your presentation and answering all of our questions. Really appreciate it.
Of course. And like I mentioned before, if you have any more questions, feel free you can DM me on social media. I'm always available to answer your questions, or even send an email. I don't check the emails as readily as social media. I check my emails maybe once per day, but still your question will be answered if you do have more questions that you'd like me to answer.
Awesome. Well, thank you so much. And thank you to our viewers for joining us today. Remember, we have an information session tomorrow with Dr. Bruce about his new externship program. So be sure to join if you're interested in that. And thank you again, everyone. And I hope everyone has a great night.
Thank you. Bye-bye, guys.